The only thing you'll be able to see is if someone is talking, you might be able to see that active person in that square if they have their camera.
Okay.
But otherwise, we won't see any like the big gallery view.
Great. Okay, we're on. Good afternoon, everybody. I'm Marshall Dahl. I'm head of the Division of Endocrinology. Pleasure to welcome you to Grand Rounds. We'll start with land acknowledgement, recognizing we're gathered on the traditional, ancestral, and unceded territory of the Coast Salish peoples, who are the Squamish, Tsleil-Waututh, and Musqueam nations, and we're grateful for their longstanding stewardship of these lands. Couple of housekeeping things before we start. It'd be appreciated if everybody could ensure that they've placed their microphones on mute so we don't interrupt the speaker. Ask if people could also turn off their videos so you're not a distraction for people who are online virtually. And then we'll move on. It's a pleasure to introduce our speaker today. Our presenter is Dr. Diana Lamb. She is an endocrinologist recently recruited at St. Paul's Hospital. She completed her medical school at University of British Columbia, her internal medicine residency, and then her endocrinology fellowship at University of British Columbia. She followed this with a year's thyroid fellowship at the University of Toronto and returned this year. And so we're so pleased to be able to recruit her and hear about her particular interest on thyroid disease and thyroid cancer, here with a presentation on thyroid cancer and primary care involvement in post-cancer treatment surveillance. Thanks very much, Dr. Lamb.
Thank you for the introduction. Can everyone hear me okay? I think so. Okay. So my name is Diana, and today I'll be presenting on thyroid cancer and primary care involvement in post-cancer treatment surveillance. I have no disclosures. And for the objectives of my talk, I will discuss a brief overview of differentiated thyroid cancer, review the management of differentiated thyroid cancer, discuss thyroid cancer survivorship care, and discuss the literature regarding long-term surveillance of thyroid cancer, specifically in primary care. So according to the Canadian Cancer Society, in 2022, it is estimated that 6,700 Canadians will be diagnosed with thyroid cancer and 250 Canadians will die from thyroid cancer. And out of the genders involved, more women will be affected than men. This is also from the Canadian Cancer Society, and it shows that thyroid cancer, compared to all the cancers in Canada, is ranked as 12 and 13 out of 22 in terms of incidence. And in terms of the mortality rate, it is one of the lowest, ranked as 20 out of 22 cancers within Canada in terms of mortality rate. And it has a very high survival rate of 97% estimated 5-year survival rate. And this is a table also from the Canadian Cancer Society, looking specifically at the statistics in British Columbia. And the predicted number of cases in terms of total cancers within BC, thyroid cancer makes up about 1.7% of all cancer cases. And in terms of mortality rate, 0.3% of all deaths related to thyroid cancer, 0.3% of all deaths are related to thyroid cancer in BC. In terms of well-differentiated thyroid cancer, there are a few types. The majority of thyroid cancer is papillary thyroid cancer, which consists about 85% of the well-differentiated thyroid cancer types. And then follicular thyroid cancer makes up about 12% of the thyroid cancer that we see. And Hürthle cell cancer also falls within the category of well-differentiated thyroid cancer. Within papillary thyroid cancer, there are variants consisting of classic, follicular, oncocytic, and then there are also aggressive variants, which include tall cell, hobnail, columnar, insular, and diffuse sclerosing. In terms of treatment, the mainstay of thyroid cancer treatment is surgery, whether all of the thyroid is removed with a total thyroidectomy or a part of the thyroid is removed with a hemithyroidectomy. And now there's also active surveillance that is ongoing being studied, where no surgery is performed and thyroid cancer is being monitored long-term. And there could also include lymph node dissection as well when in those who undergo thyroid surgery. Following surgery, patients need to be on lifelong thyroid hormone suppression with levothyroxine. And depending on the risk category of low, intermediate, or high, their TSH targets will vary. For low risk, the TSH target is between 0.5 to 2. For intermediate risk, the TSH target is between 0.1 to 0.5. And for high risk, the TSH target is less than 0.1. So for patients who had a partial or a part of their thyroid removed, usually we'd start them about 1 microgram per kilogram per day based on their weight. And for those who had a total or all of their thyroid removed, we usually start a starting dose of about 1.6 per microgram per kilogram per day in terms of thyroid hormone replacement, and then adjust based on what their TSH is on that dose. Following that, depending on their risk stratification, patients may receive radioactive iodine consisting of low dose or high dose, or no radioactive iodine. In terms of the types of treatment, under radioactive iodine, there's remnant ablation, which means treating residual normal thyroid tissue to help assist with thyroid cancer monitoring in the long term. Adjuvant ablation, which is treatment of subclinical micrometastatic disease, and treatment dose, which is treating known residual or metastatic disease. And the doses can vary. For remnant ablation, usually we do low dose, which is considered 30 millicuries. Adjuvant treatment consists of a range of between 70 to 100 or even up to 125. And the treatment dose can vary between 150 to 200 millicuries. And for those who can't undergo surgery or need further treatment, external beam radiation therapy can also be considered. And for those who are radioactive iodine refractory or need further treatment because the surgery and radioactive iodine weren't sufficient, then systemic therapy can be considered as well. In terms of risk stratification, there are a few types and systems available. The first I'll talk about is the American Joint Committee on Cancer, otherwise known as the TNM staging system. And this is an initial risk stratification used post-operatively to predict the risk of mortality in patients with differentiated thyroid cancer. So in terms of TNM staging, T1 refers to those who have a tumor size of less than or equal to 2 centimeters. T2 is patients with thyroid cancer with a tumor size greater than 2 but less than or equal to 4 centimeters. T3 is those with a tumor size of greater than 4 centimeters that is limited to the thyroid, or they have evidence of gross extrathyroidal extension, meaning invasion beyond the thyroid, but only in the strap muscles. And then T4 includes any gross extrathyroidal extension beyond the strap muscles. In terms of nodal staging, N0 refers to no lymph node metastases, and N1 is referring to regional lymph nodes. N1 is further classified into N1A and N1B. N1A refers to the centrally located lymph nodes in level 6 or level 7, and N1B refers to the laterally located lymph nodes. And then in the metastasis category, there's M0, which is no distant mets, and M1, which means distant metastasis is present. In terms of prognosis, the AJCC TNM staging system uses age 55 as a cutoff to upstage patients. So there's evidence now showing that the recurrence rate starts to increase in those between age 55 to 60. So for patients who were diagnosed with thyroid cancer and are less than age 55, they can be classified as stage 1 or stage 2, depending on whether there's a presence of metastases. And for those who are age 55 and above, the staging goes from 1 to 4, depending on their tumor size, nodal involvement, and presence of metastases. And stage 4A is if you have no evidence of metastases, and stage 4B is if you have evidence of distant metastases. And looking at the TNM staging system and the 10-year disease-specific survival, for those who are under the age of 55, they have a very high survival rate of 98 to 100% if they're stage 1, or 85 to 95% if they're stage 2. And that is also the similar rate seen for stage 1 and 2 in those who are above the age of 55. And as you can see, the 10 years disease-specific survival rate over 10 years decreases as the staging number increases. The other type of risk stratification that is also used as a Macy's score, which is an initial risk stratification system that is limited to papillary thyroid cancer only. In terms of how it's calculated, it involves looking at evidence of distant metastases, looking at the patient's age, whether resection was completed or was complete, if there's evidence of local invasion, and whether and what size the tumor was. And this is the equation used to calculate the score, and based on that score, they can correlate with 20-year cause-specific survival rates. So the lower the MESA score, the higher the specific survival rate. So for those with a MESA score of less than 6, they have a 99% 20-year cause-specific survival rate, and those with 7 and above, the specific survival rate goes down the higher the MESA, with a higher MESA score. The third one I'll talk about is called the American Thyroid Association risk stratification system, which is also used initially to risk stratify patients as a low, intermediate, or high risk to help estimate the risk of recurrence, as well as look at evidence of persistent disease. This is the one that we commonly use and refer to. So this is the 2009 version of the American Thyroid Association Thyroid Cancer Guidelines, and they proposed a 3-tiered system stratifying patients into low risk, intermediate risk, and high risk. So in the 2015, which is the current American Thyroid Association guidelines that are available, there were proposed modifications to the 2009 system. So in patients who are classified as having low risk thyroid cancer, they need to have papillary thyroid cancer with all of the following: with no evidence of local or distant metastases, having all of the macroscopic tumor be resected, have no evidence of tumor invasion. The tumor must not have any aggressive histology findings on pathology report. And if radioactive iodine was given for low risk at that time, there's no evidence of uptake outside of the thyroid bed on the first post-treatment radioactive iodine scan. No evidence of vascular invasion, either no evidence of lymph node involvement or small volume lymph node involvement, which means 5 or less lymph nodes, and the largest dimension has to be less than 2 millimeters. Intrathyroidal encapsulated follicular variant of papillary thyroid cancer also falls under low risk, as well as intrathyroidal well-differentiated follicular thyroid cancer with capsular invasion and no or minimal vascular invasion, which means less than 4 vessels involved according to the pathology report. And then lastly, papillary microcarcinoma that is limited to the thyroid with or without BRAF mutation if it is known. In terms of the intermediate risk category, this includes any thyroid cancer that has microscopic invasion of tumor into the perithyroidal soft tissues, having evidence of radioactive iodine avid metastatic disease in the neck following the first post-treatment whole body radioactive iodine scan, having evidence of aggressive histology reported on pathology consisting of tall cell, hobnail, columnar cell, and there are a few others which are diffuse sclerosing as well as insular. Having papillary thyroid cancer with vascular invasion, having clinical lymph node involvement, or if there's more than 5 lymph nodes involved, all of them have to be less than 3 centimeters in the largest dimension. And having papillary microcarcinoma that is multifocal with evidence of extrathyroidal extension and BRAF mutation if known. For the high-risk category, this includes patients who have macroscopic invasion of tumor into the perithyroidal soft tissues, otherwise known as gross extrathyroidal extension, having incomplete tumor resection, so positive margins, having evidence of distant metastases, having a post-operative serum thyroglobulin suggestive of distant mets, and having a lymph node involvement with any metastatic lymph node that is at least 3 centimeters in size. For those who have follicular thyroid cancer with evidence of extensive vascular invasion, which means more than 4 vessels involved, this also falls under the ATA high-risk category. And part of that American Thyroid Association guidelines also has a category to risk stratify the response therapy, which helps to estimate the risk of recurrence, as well as describes the clinical status at any point during follow-up. So this responsive therapy can change with time after every assessment when we see the patient in follow-up. In terms of monitoring the patient's response to treatment, imaging is often used, specifically a neck ultrasound, to assess for any residual disease or any evidence of recurrent, plus or minus a CT neck or chest if warranted. And this is usually done about 2 to 3 months post-operatively to allow for some healing to make sure there's no post-surgical changes that would interfere with the imaging, and then every 6 months thereafter for the initial time period following the thyroid surgery. And then in terms of blood work, the thyroid globulin level is often measured about 4 to 6 weeks post-operatively, and then every 6 months thereafter. And the thyroid globulin level needs to be measured with an anti-thyroid globulin antibody level, because having the presence or positivity of anti-thyroid globulin antibodies can cause the thyroid globulin level to be lower than expected. So if it is positive, in BC, there is we can measure it by mass spectrometry to spec to assess the actual thyroid globulin level. And then we also monitor the TSH as well as the free T4 every 3 to 6 months to ensure that their TSH is within target. In terms of response to treatment, there are a few categories. There's excellent response, biochemical incomplete response, structural incomplete response, and indeterminate response. In the excellent response category, it's defined as having no clinical, biochemical, or structural evidence of disease, which means having negative imaging and either a suppressed thyroid globulin level, suppressed meaning patients are taking levothyroxine, level of less than 0.2, or TSH stimulated thyroid globulin level, meaning it was stimulated by having thyrogen injections, or the patient was undergoing levothyroxine hormone withdrawal, and the thyroid globulin level should be less than 1. With an excellent response, they estimate a risk of recurrence of about 1 to 4%. In terms of biochemical incomplete response, it's defined as having an abnormal thyroid globulin level or a rising thyroid globulin antibody level in the absence of any localizable disease. And that is usually seen with negative imaging and having a thyroid globulin level that's suppressed, greater than or equal to 1, or a stimulated thyroid globulin level that is at least 10 or above, or rising thyroid globulin antibody levels. And with the biochemical incomplete response, about 20% of patients may develop structural disease. For structural incomplete response, that's defined as having persistent or newly identified local, regional, or distant metastases. And that's when you find imaging evidence, so structural or functional evidence of disease with any level of thyroid globulin, as well as with or without the presence of antibodies. And 50 to 85% of patients continue to have persistent disease despite additional therapies being used if they're in the structural incomplete response category. And then indeterminate response means having non-specific biochemical or structural findings that cannot be confidently classified as either benign or malignant. And this usually includes patients who have stable antibody levels or declining antibody levels without any definitive structural evidence of disease. So you may have non-specific findings on imaging. There could be faint uptake in the thyroid bed on radioactive iodine scanning, having a thyroid globulin level that's non-stimulated that is detectable but less than 1, or having a stimulated thyroid globulin level that is detectable but less than 10, or having stable antibody levels or declining antibody levels in the absence of any structural or functional disease. And in those patients who have indeterminate response, 15 to 20% of those patients will have structural disease identified during follow-up. So as I mentioned, in terms of responsive therapy, this is reassessed every single time we see the patient in follow-up and can change with time. So a patient who has previously had biochemical complete response, if they respond well to therapy, they may eventually develop excellent response, or excellent response can become one of the other options. So it's something that's dynamic and always reassessed at follow-up. So in terms of follow-up, there's a lot of specialties involved. Surgery is often involved initially short-term to follow up the patients post-operatively. Endocrinology is almost always involved because patients will require follow-up that is for a variable length of time to help with their thyroid hormone level adjustments. Radiation oncology is involved, especially in those who require radioactive iodine treatment. Medical oncology is involved if there's a need for systemic therapy, and family physicians play an important role as they are the main care providers for these patients long-term. So now that we've gone through a brief overview of thyroid cancer, the next part of my talk will focus on thyroid cancer survivorship care, specifically in low-risk, well-differentiated thyroid cancer. So this is a graph from the Surveillance, Epidemiology, and End Results data, otherwise known as SEER from the United States. And as you can see, the rate of thyroid cancer cases have been increasing over time, but the rates of mortality have been steady and low despite this increased rate of new cases identified. So with the increasing number of newly diagnosed thyroid cancer cases, that means more patients are needing long-term follow-up because the mortality rate is so low and patients are living much longer and not dying from this disease. And family physicians, as I mentioned, play a very important role in long-term follow-up. However, with thyroid cancer, the extended follow-up strategy is not clear. And a lot of the literature that's available regarding transition of thyroid or of cancer survivorship care to family physicians is mainly focused on other cancers, like breast cancer, for example. And follow-up is important to ensure that the patients who have thyroid cancer are receiving appropriate medical care according to the guidelines, and to assist with monitoring for disease recurrence, whether it be local or distant metastases that is evident, and as well as to monitor their thyroid hormone levels to make sure that they aren't being aggressively overtreated, because having their TSH suppressed long-term can lead to comorbidities such as osteoporosis, and also to make sure that they are not being under replaced as well, because that can also make the patients feel unwell and tired and low energy if the TSH is not within target. And to reassess the patients to make sure that they're tolerating the TSH range, because these are just guidelines in terms of ranges, but if a patient can't tolerate, you can't really have their TSH be suppressed even if they're high risk. You kind of have to relax the targets a little bit. So the first study I'll discuss was actually done at St. Paul's Hospital, and their objective was to determine whether patients treated for differentiated thyroid cancer at a Canadian center received adequate post-op follow-up care in accordance with the guidelines at the time, which was the 2009 American Thyroid Association guidelines. This was a retrospective study, and they enrolled and they include patients who had diagnosed differentiated thyroid cancer that was at least 1 centimeter in size, who had surgery here between 2003 and 2007. The patients were identified initially through the hospital pathology system, and the primary care physician was identified through a retrospective chart review, and the surveys were sent to the primary care physicians, and the survey results were compared to the ATA recommendations at the time, as well as reviewed the local thyroid cancer follow-up recommendations from the BC Cancer Agency. So out of 162 primary care physicians that they reached out to, 91 responded, and each survey was from a different family physician, and there were no duplicates. And all of the physicians cared for patients who had papillary thyroid cancer. Majority of the patients were women. The mean age was about 46 years of age, and the mean MESA score was low, 4.81, meaning these patients had a very high survival rate. And the mean follow-up duration at the time of the survey was about 3.96 years. So out of the 91 physicians, 83 mentioned that their patients were cured with no known evidence of thyroid cancer recurrence. 3 of the physicians mentioned that their patient had ongoing or active thyroid cancer or recurrence. 2 physicians mentioned that their patient died from another cause not related to thyroid cancer, and 2 physicians mentioned that their patients were lost to follow-up. So based on the frequency of follow-up modalities, as you can see, a physical exam, 67% of the patients had a physical exam within the 6 months prior to the survey. And then 20.9% of the patients had a physical exam between 6 months to 12 months of the survey. Within 2 years, only 5.5% of the patients had a physical exam performed, and then within 5 years, 4.4%. In terms of blood work that is often used for monitoring thyroid cancer, a serum thyroglobulin level was only available for 68.1% of the patients, and 14.3% of the patients never had it performed. And as I mentioned earlier, when you measure thyroglobulin level, it needs to be done with an anti-thyroglobulin antibody level to make sure that it is negative and not elevated. And that was only done in 61.5% of the patients and never performed in 30.8% of the patients. A TSH level was performed in only 86.8% of the patients, and a free T4 was only done in 68% of the patients. In terms of imaging, so a neck ultrasound was only performed in 57.1% of the patients and never performed in 39.6% of the patients. In terms of the TSH level, whether it was within target or above target, 68.1% of the patients had a TSH less than 2, and 17.6% of the patients had a TSH that was above target, greater than 2. So what the study highlighted was that there was a variability in terms of follow-up practices for patients who have low-risk differentiated thyroid cancer with obvious deviations from the American Thyroid Association guidelines. Some patients received less surveillance than recommended for low-risk thyroid cancer patients. And this is interesting because 91% of the family physicians who responded felt that their patient was actually cured or had no evidence of recurrence despite inadequate follow-up modalities. So this study highlighted that there's increased need for standardized follow-up recommendations from specialists to family physicians to improve thyroid cancer surveillance. And there's also an increased need for education on thyroid cancer guidelines to family physicians. The next study I'll talk about was also done within Canada. And the study was looking at outcomes and costs, specifically related to care of thyroid cancer patients who are low risk, who were followed in a tertiary care setting, compared to patients who were discharged at 2 years for follow-up with a family physician. This was also a retrospective study and done at 3 centers, Edmonton, Halifax, and London. So the practice at the time was in Halifax and London, in the tertiary care setting, they followed all of the thyroid cancer patients, whereas in Edmonton, patients who met criteria for discharge to family physicians, which included having a tumor size of less than 2 centimeters, classified as stage 1, having undetectable stimulated thyroglobulin level 24 months post radioactive iodine, were discharged to family physicians with clear instructions on when to re-refer back to the tertiary care center, which was if there was evidence of recurrence on imaging or if the thyroglobulin level became detectable. So the primary care patient data was obtained through the provincial health database, as well as through communicating with primary care providers and the patients themselves. The follow-up frequency kind of varied between each center and was between 12 to 18 months. And all of the costs of this study was based on Ontario information using the 2017 OHIP schedule of benefits. In terms of travel time and distance, this was calculated based on postal code of the patient's address and the tertiary care center, whereas for the travel distance to primary care, this was not calculated and it's estimated to be about 5 kilometers each way. To be included in the study, they enrolled patients who were diagnosed between January 2006 and December 2011. All of the patients had to have had a total thyroidectomy, and all of the patients had to have had radioactive iodine. The patients needed to have a tumor size that was less than 2 centimeters and classified as having stage 1 based on the TNM staging criteria. They also need to have undetectable stimulated thyroglobulin levels 2 years following radioactive iodine treatment, and lymph node status could either be no lymph nodes, unknown, or N1A, which refers to having only the centrally involved lymph nodes, centrally located lymph nodes. Patients were excluded if they did not receive any radioactive iodine, or on pathology, they had evidence of an aggressive tumor variant. In terms of the baseline characteristics, majority of the patients in both centers were females. The mean age was quite similar both. And in terms of mean follow-up, similar, about 62 months in primary care and followed for about 64 months in tertiary care. Majority of the patients have papillary thyroid cancer in both settings, and majority of the patients were considered to have T1 tumor sizing. And majority of the patients in both groups, the tumor size ranged between 1 to 2 centimeters. In terms of follow-up strategies and outcomes, looking at the recurrence rate was quite similar between a primary care setting and tertiary care setting, and all of the recurrences occurred locally in the neck. Patients underwent routine ultrasound slightly more in the primary care setting at 60.2% compared to the tertiary care setting at 52.6%. In terms of TSH target, patients were within the TSH target more often in the primary care setting compared to the tertiary care setting, and patients had a TSH below the target level more often when followed in the tertiary care setting compared to the primary care setting. In terms of economic impact, as you can see, a physician visit and the cost of ultrasound per patient per year was more expensive than the cost of similar health physician visit and cost of ultrasound per year in the primary care setting, and overall healthcare cost was more when patients were followed in the tertiary care setting compared to the primary care setting. And as expected, the travel time and the distance traveled and the cost of travel was greater in the tertiary care setting than the primary care setting. However, as mentioned earlier, the primary care setting, they didn't use the postal code to calculate the distance. They assumed distance of 5 kilometers each way. So in conclusion, the study highlighted that there were similar outcomes for low-risk thyroid cancer patients, whether they were followed in the tertiary care setting versus a primary care setting, and there was really no difference in rates of recurrence and cancer-related mortality. And this was the first Canadian study to compare outcomes of thyroid cancer patients who were followed in different care settings. And they basically alluded to the fact that low-risk thyroid cancer patients can be followed in primary care, and that's a good way, especially if they have clear recommendations on what to do with follow-up and when to re-refer back to the tertiary care setting. And they also highlighted that tertiary care follow-up with thyroid cancer patients is associated with an increased cost for both patients and the healthcare system, based on the Ontario cost at that time. They also found that TSH was more likely to be within range when patients were followed by family physicians. And because they did the study at 3 different centers, people did things a little bit differently, so they felt that their data could be generalized to the real world. And so based on this study, the centers involved, specifically Halifax and London, have been discharging their patients to family physicians, similar to the way Edmonton did it, with clear recommendations provided to patients and physicians to have the TSH blood work done every 3 to 6 months, to make sure the target is between 0.3 to 2, to do blood work for thyroid globulin levels, as well as a neck exam every year, to perform a neck ultrasound every 24 months, and to re-refer if there is evidence of thyroid globulin levels being detectable, or there's concerning evidence of recurrence on imaging. And this last study that I'll highlight was also done in Canada, and was to examine endocrinologists' perceived factors that affect the transition of care for thyroid cancer patients through a qualitative as well as a quantitative survey of practicing endocrinologists in Ontario. So the practicing adult endocrinologists, the list of the names was obtained from the College of Physicians and Surgeons of Ontario, as well as through the Ontario Medical Association, which is a mandatory membership for physicians in Ontario. And the study was conducted between March and April 2019, and the endocrinologists were emailed a survey link. And within the survey, they had 3 parts to the questionnaire. The first part was to assess in what specific scenario patients would be discharged to the family physician, according to the endocrinologist, to assess perceived endocrinologist factors to discharging patients back to the family physician. And the last question was an open-ended question for endocrinologists to describe any significant factors that they felt affected transitioning the care of thyroid cancer patients to their family physician. In terms of the physician demographics, 50.7% responded were female and 44.9% responded were male. And the majority of the endocrinologists who responded practiced in a population of more than 1 million. And those who had the highest percentage of patients with papillary thyroid cancer, their years in practice were between 6 and 25. In terms of the quantitative responses and patient populations to discharge, as shown in table 2 here, the responses were more dispersed in terms of discharging patients who were defined as having ATA-defined low-risk thyroid cancer, who had a TSH at target, but developed or reported persistent symptoms of fatigue, having multiple comorbidities that were unrelated to thyroid cancer, and those patients who had only a hemithyroidectomy despite no evidence of recurrence in the contralateral lobe. In terms of which patient populations not to discharge, there was a consensus among the endocrinologists who responded that patients who were defined as having high-risk disease according to the ATA guidelines, they did not discharge. Patients who had evidence of enlarged cervical lymph nodes or small lesions in the thyroid bed, even if they are nonspecific and not growing, were also not discharged. If there was evidence of neck disease that was persistent in the neck, even though not progressing, endocrinologists tend to continue following these patients, as well as if the patients had persistent disease in the lungs, even though it was stable. In terms of factors affecting their decision to discharge, the majority of endocrinologists responded that this included whether their recommendations will be followed appropriately by the family physician, whether they felt that the family physician was capable of how to adjust the dose of levothyroxine, and whether their patient perceived whether the patient had confidence in the family physician's ability to manage the patient's thyroid cancer. So in terms of the open-ended question, 51 out of the respondents, 51 out of 70 of the participants responded regarding other factors or barriers that they felt affected the transition of care from specialists to primary care physicians. And there were 4 main themes that emerged as factors affecting the decision to discharge. As shown in Table 4, the first theme was primary care physician related. The respondents commented that primary care physicians expressing a lack of confidence in managing thyroid cancer. They felt that was a factor that affected their decision to discharge the patient. There was a lack of clarity if the family physician has knowledge on how to manage low-risk thyroid cancer. It was kind of unclear. There's a high rate of re-referral when the patients are discharged to the family physician. And lastly, some of the patients don't have a family physician, so that definitely did not allow for discharge. The second theme were patient-related factors, which include patients requesting to be followed by an endocrinologist, and patients having some anxiety or expressing anxiety that they're not being followed by a specialist for their thyroid cancer. The third theme was imaging-related factors, which focused on a lack of universal high-quality ultrasound interpretation available in the community, as well as non-specific ultrasound findings. And these can be common, and there's often a lack of clarity in terms of what to do with these. So oftentimes the endocrinologist will just continue following the patient. And then the last theme was guideline-related factors, which focused on a lack of knowledge on when to discharge patients from specialist to primary care. And there are no standardized handouts to provide primary care physicians or patients upon the time of discharge. So in conclusion, this was the first study to look from the specialist's point of view about thyroid cancer survivorship care, because most of the literature was looking at from the family physician's point of view. And the majority of the endocrinologists were in agreement that long-term follow-up is appropriate with endocrinology in certain patient types, specifically ATA classified high-risk thyroid cancer patients, those who had non-specific cervical lymphadenopathy on imaging, those who had evidence of neck disease that was stable, as well as evidence of lung disease that was also stable. From this study, endocrinologists lacked confidence in primary care physician follow-up, specifically relating to medication changes and adjusting it based on the TSH levels. And they're also worried about their recommendations not being followed. And there's also a perception that patients prefer follow-up with specialists, and that patients may lack confidence or trust in their family physicians for further follow-up in terms of their long-term thyroid cancer surveillance. And there's also a lack of confidence and willingness from the endocrinologists themselves to transition care to the family care provider. So with the number of thyroid cancer diagnoses rapidly increasing and patients are living longer with a very high survival rate and low mortality rate, thyroid cancer patients are living a lot longer and therefore need longer term follow-up. And in summary, treatment, as I mentioned previously, was consisting of surgery or no surgery, whether it be total thyroidectomy or hemithyroidectomy. Subsequent treatments following that include TSH suppression with levothyroxine, radioactive iodine if indicated, external beam radiation therapy or systemic therapy. Patients long-term need to be monitored with imaging and blood work. And there's a need for guidelines to assist with transition of care. And as we can see, thyroid cancer patient discharge patterns do vary between specialists, and there's no standardization in terms of when to discharge the patients at what time point, 2 years, 5 years, 10 years. And the role and responsibility of each provider needs to be clear in terms of managing which aspects of thyroid cancer. And so we really need to involve and support family physicians and provide clear recommendations on follow-up guidelines and when to re-refer. And in addition to supporting and promoting confidence of family physicians, this can be done through maybe CMEs or good communication on terms of follow-up recommendations. But yeah, that concludes my talk.
That's great. Thank you very much. You have the microphone here with you. So that was great. It was really interesting to just have a review of the fact that this is a prevalent condition that can do really well for low risk people with people doing the right thing, which is systematic approach to monitoring over decades.
Mhm.
And that demonstrated that people can do well in that category in a shared care environment with clear communication with primary care. And I guess those are things that could be generalizable to a number of conditions outside of thyroid cancer as well. So I guess one of the things I'm wondering about is what would be the patient role in this? Has anyone studied the actually handing, for instance, a set of patients, a set of recommendations about this is what we're corresponding with your primary care practitioner, either family doctor or a nurse practitioner? This is our expectation of what they'll be monitoring for you every year or so. And if it's going well, you probably don't need a specialist. Any idea about patient role or patient partnership in this?
Yeah, there are a few studies. I didn't look into it or include it in today's study, but there are a few studies available. I believe it's done out of Ontario as well, where they interviewed patients in terms of how they felt their care was being delivered from a family physician perspective and a specialist perspective. But I didn't include in my talk for today, but there are studies out there. But I believe it's quite variable because it depends on patients and how confident they are with their family physicians in terms of managing thyroid cancer. But yeah, there are studies out there, but I didn't include in my talk today.
Okay,
Mhm.
Carson.
Thank you for the presentation. If I were a family physician, I'm not sure I'd take this on. And the reason I wouldn't is that there's so many things that I'm following. I'm not sure I would be able to keep up with the guidelines.
Yeah.
So even if you saw a patient and recommended something to follow, now it's 2 or 3 years out. And I think it puts a lot of onus on the family physician to do a variety of different things.
Mhm.
So that would be from a family physician's point of view. And from the endocrinologist's point of view, I'm not sure why, as an endocrinologist, I wouldn't want to follow this group of patients. So maybe you could respond to those.
Yeah, I guess with the increasing number of cases, that means more patients are following up. And I guess if we follow them all for long term, we might not have enough room to see new consults or take care of new patients who have more high risk thyroid disease. So I think from a specialist point of view, I think if they're low risk and they're able to be managed in the community, I think that probably be a good idea to kind of transition care. But obviously, if they're high risk or intermediate risk, that we should play a bigger role in following those patients long term. I think it's just I guess it depends on how sustainable it is to follow every single patient with thyroid cancer long term in the practice. I guess that plays a role.
Well,
Yeah.
sort of just following that same theme.
Yeah.
I mean, diabetes is followed pretty much regularly by endocrinology,
Mhm.
a chronic disease. So how do you, I'm not sure I quite understand the volume of patients with thyroid cancer is
Yeah.
certainly not in the same.
No, definitely. Yeah, that's a good point too. Yeah, I'm not sure, Dr. Dahl, do you have any with your
I think there's these
yeah.
are resource issues province-wide. I point out there's a number of types of primary care practitioners, so nurse practitioners, family doctors as well. And they all have people have different comfort levels with certain conditions. So I think if we extend through that, you'll have a number of primary care practitioners who say, I'm totally comfortable finding this well-controlled person with diabetes and doing that. I'll take it from here. I'll let you know if there's a problem. There's probably a number of primary care practitioners who, upon receiving these really clear instructions about thyroid monitoring, would say, okay, I've got this. I'll be checking the blood work. I'll be doing the ultrasounds. I'll let you know if I meet the standards for re-referral or if I've got another question there. Others are less comfortable and are more likely to re-refer, but certainly the ability to do shared care is going to increase with clear communication about low-risk patients. So it's another one of those it depends answers. So I think it depends on the circumstance and the practitioners involved. One of the things also that comes up would be, I find people often have questions about what to do. My patient with well-managed thyroid cancer is now pregnant. What considerations should I take in terms of thyroxine dosing and monitoring, please?
Yeah, so with pregnancy, it's a little bit harder because it is variable between patient to patient in terms of how tolerant they are of the TSH targets. So for those who are on a high risk TSH target, we try to keep them there if they can tolerate it, but obviously we keep a closer eye on them compared to other patients who are on thyroid hormone replacement for other reasons, just because there's a risk of over-suppressing and a risk of side effects as well as risk to fetus as well. So if we can, we keep them suppressed, but we try to kind of, relax the target a little bit if they can tolerate it. And because these are just, there's not great studies in terms of like the TSH targets need to be within this range, and this range for low, intermediate, high. So in pregnant patients, if they're doing well and they're tolerating the suppression, then we kind of keep them at that range. But we try to keep them at the range that they were originally on before pregnancy. But if they can't tolerate or there's any concerns, we don't hesitate in terms of backing off on that.
Other questions here within the room? And other questions from those attending virtually? Feel free to just unmute and speak.
Hi, Marshall. It's Sabrina. I just wanted to sort of respond to, and echo what Diana said. With thyroid cancer, especially with the high risk, I think it's pretty easy that they should be followed by endocrinology. But I think as Diana clearly showed, which was a great talk, by the way, Diana, was that a lot of these patients can be maintained just with good surveillance. And I know we do it, and the cancer agency does it as we discharge patients. You give a letter detailing what needs to be done. One note goes to the family physician, one note goes to the patient. It would be, though, maybe it's something that we should do. It'd be a great QI project to see what how family physicians, but also patients respond. Because I can say from personal experience, patients are the ones that are more anxious about leaving. And so it is a bit of a resource issue because there's only, as Diana said, there's only so many endocrinologists and there's only so much you can manage. And I think the cancer agency is dealing with the same thing. And so it's just a matter of having really wonderful family physicians that can manage. And then, the door is always open. They can call you anytime if there's anything. They CC you on your results. But I think it's having that partnership with family physicians is essential because we're seeing more and more thyroid cancer quite regularly. Unfortunately, a lot of them are low grade that they can be, once have their initial surveillance for 3 to 5 years, they can be well managed with their family physicians.
Good, thank you. Other questions from those attending virtually? Just unmute and speak, please. That's very good. So before thanking our speaker, I'll just remind people the next presentation will be a week today on December 15th. It will be the Division of General Internal Medicine. The topic is obesity, a changing paradigm, and the presenter will be Dr. Nadia Khan. So I just join me now in thanking Dr. Lam for an excellent, organized, super clear presentation of an important topic of a prevalent condition that does well with the right amount of organization. And we look forward to Dr. Lam's ongoing work in this area. Thank you very much. Have a good day, everyone.